Welcome to the MS Center of St. Louis educational program. We do this at least twice a year. We very much enjoy it because it gives us the freedom to select topics that we think, we being the staff and your faculty this morning, that we think might be of interest to people with MS now in 2016. And so our topics vary from program to program, so if you've never been here before, we hope you'll enjoy it, and we hope you'll come back next time. The reason we're talking about other illness this morning, not specifically MS, is because there is an increasing interest and an increasing literature and more insights into the fact that there are diseases separate from MS that are in fact linked to multiple sclerosis. And there are also diseases that having MS seems to in fact predispose people to getting. So let me say that again. There are a set of illnesses which, if you already have multiple sclerosis, you may have a predilection for getting some of these other illnesses. And so we have, in our MS Center particularly, begun to focus on what we call the comorbidities of MS. And that a lot of people said to me, what the heck is that comorbidity thing? What's that word? And comorbidity just means another set of symptoms or another disease that accompanies MS. And people with MS, in fact, have this predisposition to certain comorbidities that develop over the course of MS. But in addition, we are learning that there are also certain comorbid conditions that have a high association with getting MS. And it's on that we want to focus a little bit this morning. Why? Because we want to make sure our patients stay healthy. Comorbid conditions, about which we're going to talk this morning, cause other symptoms, cause other complications, and by doing that, they may decrease the quality of your life. And so what do we always want to do when we're treating people with MS? Sure, we want to control the MS, but the overall goal is to optimize, to maximize what your life quality is. And that's, again, going to be our focus this morning. So a lot of people throw around these terms health and wellness and so on and so forth, and most people in their brain, they're going, oh, she's going to talk about exercise, okay? That theme we keep coming back to in the office. Yeah, we talk about exercise, but there are many other management devices, management pathways that increase quality of life, okay? So if somebody in your family happens to have diabetes, you know that diabetes can seriously impact on life quality, right? Well, it turns out that MS, for example, can increase weight. Sad to say, okay, but it can. It is associated with obesity. And what is the major comorbid condition that accompanies obesity in America? It's diabetes. So we have many patients who have MS, who also have obesity, who also begin to develop or have diabetes. And those types of illnesses can greatly impact on their health and wellness. So look at it as a connective map, if you will, as you can see here, okay? There's MS, and there are certain risk factors for MS, and more we are discovering that sometimes lifestyle influence can impact getting MS. It turns out that obesity in adolescent women increases their risk for getting MS, okay? Just one example. But there are also risks once you have MS that will modify your disease. It turns out that if you smoke, your likelihood of progressing with your MS is greater. So there are all these connections, if you will, between various comorbid conditions and how your MS comes on and how the course of your MS proceeds. And so we very much want to impact not only on getting MS, which once you come to the MS Center, most likely you're coming there because the diagnosis is in place or going to be in place, but we want to influence how it goes the rest of your life. And what quality of life can we get you that will really be maximal? And those include things that you see up here. We want good physical health for our patients. We want good emotional health for our patients. We want your lifestyle to be maximized to be what it can be, okay? To get you still working, to get you still playing, interfacing with family, interfacing with your community. We want to optimize your overall health. And so here's just a short list of other comorbid conditions, and you'll see that what we did this morning was we picked a few on which we're going to focus, if you will, because there are many, okay? And at other of our programs, we've talked about some of these others either directly or indirectly, and it isn't that we aren't going to get back to them again and again over time. We know if you look down the list that fatigue is a huge problem for people with MS. Turns out sleep disorders are common in MS. Okay? Autoimmune diseases are comorbid with MS. Many people with MS also have psoriasis, also have thyroid disease, also may have things that are a little less common, Crohn's disease or ulcerative colitis or rheumatoid arthritis. These are comorbid other autoimmune conditions. But many patients with MS have a predilection, a predisposition to getting seizures, to having depression, or in fact to having headache problems. And that's where we're going to focus this morning. So I don't want to steal any thunder from our later talks. I want to let you know that the MS Center of St. Louis has billed itself as a comprehensive care center for many, many years. And we did this not because we thought of ourselves as taking care of every other medical condition that you have, but in fact, taking care of the broad health of the individual, practicing what we hoped was holistic approaches to MS, addressing not only the disease process, but the accompanying symptoms and complications. But now, in this day and age of understanding comorbidity, we're adding to that. And what we're adding now is a focus on overall health. Not that we want to become your primary care physician or your gynecologist. God help me, no thank you. That's why I went into neurology. Don't want to go at the other end. No, thank you. But we are focusing on overall health, and in so doing, we've developed a process at the MS Center for you to meet with our advanced practice nurse, Mary Kay Fink, and you're going to hear from her this morning, to address your overall health. And we call it an MS healthification visit, in which physical findings, lifestyle discussions of CAM, complementary and alternative approaches to your health, what the emotional impact is of your MS, all of those things are things that Mary Kay is now addressing on a regular basis with patients. So we feel if we've got your MS under control, how can we still up your quality of life? So Mary Kay will give you a little bit more information about that later. But I want you to all enjoy our next speaker. My wonderful partner, Dr. Amy Rauchway, is going to come up here and talk to you about a topic that's near and dear to her heart. Amy is a wonderful MS neurologist who also has a very broad expertise in general neurology, and in so doing, we've lateraled to her a lot of our headache patients because she's extremely good at analyzing and addressing issues with respect to headache, and that's what she's going to talk about this morning. So welcome, Amy.
Good morning. It's a pleasure and honor to be here today, and I'd like to thank Dr. Green for that wonderful introduction. I hope I can live up to her expectations and everybody else's expectations. I will, as I say, my intention is always to do my best, and we'll see what the outcome is. So today I will be talking, there are many, many kinds of headaches. Today we'll be focusing on migraine. Even within the area of migraine, there are several types of migraine. And so today we're going to focus and discuss how commonly migraine occurs. Is this an infrequent problem or is it a common problem? And the relationship of migraine in MS, how often it occurs there. And then we'll look at 2 case studies of people with MS and migraine and learn many of the key points based on the case studies. Let's talk about what we call the epidemiology. So when studies look at statistics of disease, they do it in a number of ways. One way to look at the numbers is to look at the 3-month prevalence. And so that's how often this disease occurs over a 3-month period. And migraine is 20% in women and 9% in men. And so we can see already there's a larger proportion of women affected than men. If we look at in terms of an entire lifetime prevalence, if we extend it out, the numbers are even higher. So the lifetime prevalence for migraine in women is 43% and 18% in men. Another way to look at it is how many people are affected. So in the US, 1 out of every 7 has migraine each year. And interestingly, it's the 4th leading cause of visits to the ER. So we hope that our ER docs are well versed in how to treat migraine, and they certainly are. There's also a hereditary component to migraine. It typically runs in families. So one of the questions I always ask a person, anybody else in your family have migraine, a parent or a sibling? It's not just one gene that produces this, it's many genes involved. And we think it's an interaction also of environmental triggers and somebody who's already susceptible to migraine. Does that sound familiar to you? Have you heard that phrase before? Environmental triggers and somebody who's susceptible to a disorder? I'm beginning to see that there are some, at least, commonalities to MS. It's not an easy disorder to have. It's quite disabling. And first and foremost, it's underdiagnosed and undertreated. There are people who think, oh, I can get through this, and then they're in the midst of their headache and they're calling their workplace, they can't work, they can't cook the food on the stove. It's quite disabling. The peak time period is between the ages of 25 and 55. Doesn't that sound similar also to the ages in which people get MS? So in terms of how it affects everyday life, up to 93% of women with migraine have lost work on account of it, calling into the workplace, and even productivity is decreased. So you may be able to stay at work, but it just takes so much more effort, can't think through, can't problem solve, so decreased by 50%. And in fact, if those who stay at home, their household work is reduced by 67%. So these are not minor numbers. And even in terms of wanting to go out and have fun with your family and go to social activities, 59% reduction. So this is disabling. Let's take a look at this in another way. The same numbers looked on a graph, and we can see there's a 90% of work loss. Then comes school and work productivity loss being affected. We said that number was about 50%. Household work is also diminished. And then, importantly, family and social activities. This really affects the quality of life. As Dr. Green mentioned, there are comorbidities in MS, and there are comorbidities in other conditions as well. And so a comorbidity means 2 things all at the same time, or even more than 2 things. So it's common to see people who have epilepsy also have migraine. It's common to see migraine and depression occurring together, certainly anxiety, and also in MS. Let's see who migraine affects. In MS, and which we're specifically addressing today, the numbers range widely. Depends on which study you read, but it's certainly there, and it's all the way from 4% up to 64%. So that's more than half. And it can be difficult for the person with MS who has migraine when that person has a symptom to sort out what is the problem? Is it related to my migraine? Is it related to an MS symptom? Because some of them may be similar. And in fact, we know that MS medications may worsen headaches. And so that affects our treatment program and our treatment management for people in our office, in our center, when we're choosing medications, both for their migraine and both from an MS point of view. There are always medication interactions, as you know. And so when somebody who has MS and has migraine, there are differences, and there are differences among the patients who just have one disorder and compared to people who have both of these. And what studies have found out, what researchers have looked at, in that people who have migraine and MS, there's a significant increase in their pain symptoms. And there's also an increase, interestingly, in the non-pain symptoms. And so it's not a surprise then, if you have MS and you also have migraine, that maybe you have some extra extremity pain, or maybe there's some general increase in sort of overall body aches and pains, or even spasticity, the non-pain symptoms. It's all escalated up. Let's talk a little bit about what a migraine is. And for those of you who are not affected, this can be educational. We think of it as a person who has what we call a hyperexcitable brain. There's one big trigger that's been known for, it's been described and better understood over the years, called CSD, which is cortical spreading depression. And we'll talk a little bit more about that in a minute because of its importance. Generally speaking, it's thought to be a wave of brain activity that travels up the brain and then calms down or suppresses, and it is considered an abnormal state. When you think about the brain in terms of its anatomy, because migraine is so complex, as we mentioned, it's already, the factors that go into migraine is a person's susceptibility, environmental triggers, and the anatomy plays a role too. And so I'm not sure if you've been aware of it, but did you know that the brain is not innervated by nerve fibers, the brain itself? So we don't experience pain in brain tissue. But take a look at all the other structures in the head. The coverings around the brain, the thickest covering is called the dura, the vessels on that dura, the face, the ears, the eyes, those all have pain fibers. So it's not unusual when you have a headache to also have eye pain, to have face pain. And that pain, and maybe perhaps that's why it's called a headache rather than a brain ache, that pain from the head is referred into the neck, and there are also pain fibers in the neck, and pain from the neck can get referred to the head. Generally speaking, and this is just a short anatomy lesson, not a long one, the head is innervated by what we call cranial nerves, and the large player for headache pain is cranial nerve 5. It has 3 branches, 1, 2, and 3. Below the level of the head is innervated by fibers from the cervical region, and we usually think of those as the high cervical regions, for example, the level of cervical 2 or C2, generally speaking. There are criteria for migraine. There's not a test. I can't run a blood test on you and say you have migraine, but we have criteria, and this is what is stated by the IHS, or the International Headache Society. So if we're looking at one of the types of migraine called migraine without an aura, and we will be discussing aura in a moment, a person has to have at least 5 attacks before you can ever get that diagnosis. So if you have 1 or 2 attacks, we might say this is a probable migraine if it meets all the criteria, but you formally don't get the diagnosis. They're long headaches. They last untreated, anywhere from 4 hours up to 3 days, and they have the following features. You have to have at least 2 of these following on my list. It can be one side or both sides. It can be pulsatile, or a name that we often use is throbbing or pounding. That's what you feel. You don't really walk around saying I have a pulsatile headache, but you said my head pounds. And they can be moderate or severe. So I've had some patients come in and say to me, oh, I don't have headaches like my husband. He has to go to bed and throw the covers over his head. Those are debilitating. I just have, moderate size headaches. Well, what do you know? You can have a moderate amount of pain and still be a migraine. And it's worsened by routine physical activity. That means when you get up and start moving around, or even head movement, that headache worsens. Lastly, one of each of these 2 categories, which I'll point out to you. One category is nausea and or vomiting. So you only need nausea or vomiting. You do not have to vomit in order to have a migraine. It can even be just a queasiness to your stomach. But if you're sensitive to light, to fit that category, you have to have sensitivity to light and sound. And so while all this sounds complicated, basically a migraine is one of those headaches that it's either moderate, severe, it pounds, when you move around, you get it, it becomes worse, but it becomes much better if you go to rest in a dark environment with no sound. That's a migraine. And so here's a picture of the brain, the cortex, and then the brainstem and the cerebellum. And this is just showing the very, very start of what we call that CSD. Now, in this brain activation, just briefly, because this can get to be quite complex, that activation of the brain releases certain substances. Some of them are well known, like potassium or even protons, but it's those substances that send a signal to other messengers in the brain. And those messengers land up sending other signals to the blood vessels. And at that time, the blood vessels dilate or get larger. And when those blood vessels dilate and get larger is when you have that pounding head pain. And that's when you start to hold your head and say, oh, okay, I know I have a migraine. The important point here, if I can't stress this more than enough, is that's the time the migraine is treatable. That's when you need to take your migraine medication. It has a fancy term. It's called peripheral sensitization. If you let that migraine go a little bit longer and say, oh, I'm just going to see how this plays out, then you start to get scalp pain. That's when you get the face pain. Then it's hard to treat. That's when you start taking meds and, oh, this one didn't work and that one didn't work. And then you start going to one physician or another and they say, oh, I see you tried this. Now we have to ramp up the therapy. And you start to run out of medications that are possible to use. If you had taken the medication at the onset of the headache, there's a much better chance of treating it and having it go away. Okay. Now we'll look at one particular kind of migraine that's quite common in women. Of women with migraine, more than 50% or about 50% have what we call as menstrual migraine. There's 2 types of menstrual migraine. One is a pure menstrual migraine, that's in 14%, and the rest of those have menstrual associated migraine. So a menstrual migraine is a migraine that occurs during that cycle of when women have their period. And it can occur anywhere from what we call day -2, so 2 days before it starts, all the way into that cycle. A menstrual associated migraine is a migraine that occurs then, but at also other times of the month. Typically, this kind of migraine is a migraine without aura. And so I just gave those definitions. And this was taken from one study that looked at the drop in estrogen, and that's considered the trigger for these menstrual migraines, because when the estrogen drops, as I show you here, it plummets here, that's when the headache starts. The important part to know about menstrual migraines is that they're hard to treat. And this makes them uncomfortable to women who have them because we try multiple regimens and we're not always successful. And so you really need to speak to your healthcare provider, because if you try to manage these on your own, you may run into a bit of a problem. And we use something called a mini prophylaxis or a mini regimen. That can be quite successful. And so let's take a look at a person, somebody who has MS and somebody who also has migraine. So this is our first case study. It's a 43-year-old woman with MS. She's had migraines for years, and the migraine occurs at the start of her menstrual period. But she also has 2 additional attacks per month, so really, truly, her diagnosis is a menstrual-related or a menstrual-associated migraine. So let's see, does her headache meet the category of migraine? It's pounding. That was on her checklist, right? It's associated with nausea. That was on our checklist, so no vomiting, but just nausea. And she's sensitive to light and sound. I opt for saying that's a migraine. Everybody else does too? Okay. She was disabled. We know that now. And she was unable to continue her daily activities. Okay, so this is interfering with her quality of life. She's at home. It's hard to get out and about. She's got MS. She has mobility problems. So what did she find in her cabinet? Some Tylenol. So she took acetaminophen, 1,000 milligrams. Now, Tylenol or acetaminophen can be used for mild to moderate migraine and can be used with success. It has to be used appropriately, so really speak to your physician about it. And so for her, with her headaches at the other times in the month, it was helpful. It didn't fully resolve the headache, but it had no effect on the other more severe ones. So we started her on a preventative medication. And there are FDA-approved medications for the prevention of migraine. And these are not over-the-counter. These are prescription medications. They come in 3 major categories, either anticonvulsants, such as we use in epilepsy. They come as antihypertensives, specifically the category called beta blockers, and also the old-fashioned antidepressants. We call those tricyclics. Within the anticonvulsants, we chose topiramate for her. And then I added in a mini prophylaxis regimen. So for acute treatment of migraines, if somebody is eligible, we like to use a migraine-specific medication, and those are the triptan medications. And so we started her on one of those. It was called naratriptan, and she took it twice a day from that day -2 to day +3. And I even said, why don't you just increase your baseline Topamax dose just during those days of the cycle only? I also added some magnesium because studies have shown to us that a person who has migraine is also thought to be magnesium depleted. Now, luckily for us, her headaches came under control. Not entirely, but enough that she was quite happy. If that doesn't work, you can speak to an OBGYN, and something like hormonal prophylaxis or adjusting a birth control pill, for example, may be effective. Now let's move into the migraine with aura. First, we need to discuss what an aura is. And an aura is a reversible. It means it comes and then it goes away. It affects your vision, your speech, any kind of sensory problem. Sometimes it has positive features, so you see something there that shouldn't be there. And sometimes it has negative features, so you're missing something for your vision. And it has to develop over 5 minutes. And sometimes auras happen one right after the other. So a person may have a problem with their vision, and then a problem with their arm may tingle. And so for a person who has multiple sclerosis, one might be saying to oneself, okay, my arm is tingling. Is that MS or is that a migraine? But it's short-lived, generally speaking. Each symptom is between 5 minutes and 60 minutes. See that abnormality? That's called a visual fortification spectrum because it looks like the spikes on one of those old medieval forts, and it just plops down right in the middle of your vision and obstructs what you're trying to see. And to get that diagnosis of migraine with aura, this time you don't need 5 attacks, you only need 2. And once that aura is over with, the headache starts. Sometimes it can even start with the aura. So let's look at case study number 2. This is a young woman with MS. She's had multiple attacks of migraine with aura, and her aura was described to me as kaleidoscopic vision. Remember we used to look through those kaleidoscopes as kids and the vision is all broken up? And then she would have a moderate to severe headache afterwards and nausea, but no sensitivity to light or sound. That still meets our criteria. She was on an MS medication called glutathione acetate or Copaxone. She also worked shifts in her job. Sometimes she worked a day shift, sometimes she worked a night shift. And she had 2 young children on top of all this. So that's quite a large burden on a young woman. And she was taking combined oral contraception. So what did we do? When she came to my office, I said, number 1, let's have you speak to your OBGYN about other alternative forms of contraception, because we know that there's an increased risk for stroke. It's small, but there is an increased risk for stroke among women who have migraine with aura. And so that risk is even increased more when you're on an estrogen progesterone contraceptive pill. And so I asked her to go speak to her OBGYN, and I said, let's start one of those tricyclic medications. We started with nortriptyline, we added magnesium. The small dose of nortriptyline didn't help, I increased it. She spoke to her husband, and he elected to have a vasectomy. That was what you call teamwork. Then, from her MS point of view, she developed restless legs. Some of you may have that. So I added gabapentin on top of that, and then she was stable. However, for a number of reasons, we switched her to one of the oral therapies for MS. And then she had some leg uncomfortable pain, and it wasn't part of her RLS. And then she started developing vertigo. So here I thought, oh, everything was going just fine, but we imaged her. So I said, could this be your MS? We imaged her, and there were no new lesions. So what did we do next? In terms of the legs, I switched her from nortriptyline to Cymbalta, which is another antidepressant. It's an SSRI, and we know it works well for pain. And we changed her preventative to topiramate or Topamax, and we started a migraine diet. And since we know food is one of the triggers for migraine, there are such things as migraine diets in which you can alter your diet to not act as a trigger. I added several options to her. She lives way out of town, and so I said, here's a list. You can try one of these when you have an acute headache. So we had a triptan on board. For milder headaches, you can even try aspirin, and I gave her the appropriate doses. I gave her a triptan as an injection. Those are great because they work right away, very quickly, and work well for people who have a lot of nausea and can't tolerate an oral medication. She had already experience with knowing how to inject, so she had no problem taking an injection. And we also gave her a medication that's a powder that works well, and that's in the same class as, say, for example, ibuprofen. I added on Nuvigil. It's a similar drug. Some of you may be on Provigil, and we added that for give her a little energy boost for her shift work disorder. And then, lo and behold, her leg pain came under control, her migraines came under control, her MS was stable at that point, and her fatigue came under control. So this is an example in which we say all those other MS symptoms can ramp up when you have migraine. So when we treat migraine, we use something called a stratified approach, which means we use a preventative medication, and then if the migraine breaks through, we use one of those acute therapies. And from an underlying medical point of view, because some people don't really want to take a preventative because it's an everyday medication, we think that that works on that CSD pathway, so it decreases that threshold, and so it's actually is a preventative. It's not just taking a daily medicine. And we think when the migraines break through, they may even be less severe. These are not pills that work, overnight. They have to be tried and not abandoned right away. And so an adequate trial is considered at least 2 months. 3, yes, but sometimes that's really hard to do because when somebody's in pain and they're not necessarily going to want to say, okay, I'm going to take this for another whole month. I always try to avoid medication interactions based on their mechanism of action primarily. And also, of course, if somebody is contraindicated to a medicine. So for example, if somebody has asthma, we stay away from those beta blockers. And keeping a diary to describe that headache so that I know how often it is, what the features are, for me to figure out if it's with aura or with not aura, is very important. A diary can be handwritten if you prefer, or there are now apps right on your smartphone that you can use, and that's kind of fun. So what are the general principles of prevention? We talk about comorbidities. So do you have migraine and high blood pressure? Or in addition to the MS, migraine and, for example, depression, then we might choose another medication instead. It's always wise to have a remedy for nausea and to monitor for what I call medication overuse. There's a whole other kind of headache. It's called a medication overuse headache. When people start to use these analgesics, Tylenol, Excedrin, and even the NSAIDs, those ibuprofens and Aleve, on a daily basis, you can launch yourself all into another kind of headache that's very challenging to get rid of. It's what other people have called a rebound headache. It's a chronic daily headache. And then these medications don't have to be lifelong. We can taper down that preventative once the migraines get under control. These are the therapies we use in the acute headaches. So we looked at it in the case study, but I'll just review them again. So we have triptans. Those, for example, you might have heard of sumatriptan. That's a very popular one and can kind of be used as like the example for those. Aspirin can work. Ibuprofen, ketorolac is another one of those NSAIDs, naproxen, and also diclofenac. Let's take a quick look at some of the medicines we use to treat multiple sclerosis, since we're talking today about migraine and MS. And generally speaking, I'm not saying for every individual, but generally speaking, in the use of interferons, headaches are generally perceived as more frequent and more severe. But let's take a look at the numbers. So on interferon beta 1A, 44 micrograms subcutaneous, above placebo at 7%. With the 30 microgram dose, it's 3%. And with the 125 microgram dose, it's 11%. With beta 1B, it's 7%. With glutathione acetate, 2%. When we go into the oral therapies, we have fingolimod, that's 1% above placebo. I didn't have a number for dimethyl fumarate. Aubagio, 1 to 3%, and natalizumab, 5 to 9%. So they vary, and it's just something that we take into consideration. It doesn't mean it's contraindicated, it just means that we know we have to kind of work around it if we need to. So in summary, migraine, what did we learn? It's common, it can be disabling, it's very important and helpful to yourself and also your physician to use a diary to us to know what your features are. And then for somebody who has MS, it can help you to clarify what's related to the migraine and what's related to your MS. And then please work with your provider to optimize your treatment in both disorders. I've given you some resources here. This Migraine Buddy is that app that you can use on a smartphone to track your migraine, and it has other features on that site as well. And then the American Migraine Foundation has a website for patients on tips for living with migraine. And thank you for your attention.